But thank you all for coming. We'll start at 7:03, let's say that. Okay, let's get going. I'll introduce myself and people trickle in as we do go through the introduction. But welcome all to our third lecture of the year. And this one is on cardiology, so it's one of the big medicine topics. Often quite scary, often hard as well. But hopefully we manage to kind of cover the big topics and hopefully make everyone understand a little bit better by the end of this talk. I'm always encouraging like interaction and you guys asking as many questions as possible, and that's really part of the benefit of you guys coming and attending this live. So it's going to be a mixture of SBAs, it's going to be a mixture of kind of explanations as well, but also please, if you have any questions, just pop it in the chat, be very happy to answer. And I want to make this really as interactive as possible as well, just to kind of make everyone's learning a bit better too. This will be recorded, yes, okay, and we'll publish it hopefully on YouTube and definitely on Medal too, okay? So to Registry who asked that question, it will be recorded. Cool. So let's get going. My name is Eamon. I'm a currently cardiology F1 at Newham Hospital, part of Bart's Trust. My BSc was in cardiology and back at med school, and it's kind of the subject I'm most interested in. I'm also the Mind the Bleep final year lead as well, so we're kind of running this months-long series for you guys, really, and we're hoping to cover pretty much every single subject mapped to the UKMLA. So this is only the third of really what should be about 30 different webinars. So, just keep an eye out on our Facebook, on our Medal, but also we've got some med school reps as well you might hear from, and they'll be kind of messaging along, keeping you guys updated as well. But, right, let's get into the cardiology side of things. So, today we're going to cover, really, I tried to pick the main topics and the things that are most likely to come up. Acute coronary syndrome, by far, the most pressing, the most emergency, and actually very common as well. So we're going to go for that. Heart failure, hypertension, atrial fibrillation, and a little bit of heart block, but actually not too much, and then valvular heart disease as well. Unfortunately, we have an hour. We might go over. We very well could go over, but it's impossible to cover all of cardiology. So there's a lot of other things that we won't, and I've just listed them there just so you guys are aware of. If people want, then we can always do another lecture as well to kind of give a complete overview of cardiology, and that's something I'd be very happy to do in the future too. And this is your MLA curriculum content map. Now, again, this is new. Not everybody is going to be using this, but even if your med school isn't using this, it's still a good guide to kind of understand what you need to know. The annoying thing is they've kind of mixed cardio with vascular, and it's not specific in the slightest. So you can look at things like pericardial disease. Like, what does that mean? So it's not super useful, but at the same time, it's definitely a good guide to point you in the right direction and make sure you are ticking everything off. So I would really recommend mapping your revision to this, especially if your med school is using it as part of your exams, which I think many are this year, and more so definitely next year. Right, so I said there'll be SBAs. I'm just going to make a poll. Sorry, just give me a minute. Okay. So this is the poll. I'll just read you through the question. So, a 62-year-old man presents to ED with a 1.5-hour history of central crushing chest pain radiating to his jaw. He's diaphoretic and nauseous, but does not complain of any dizziness. His observations are stable. He has no known past medical history. An ECG is performed and is shown below. Let me show you next. This is his ECG. I'll give you guys a few minutes to look at it. Okay. And these are the answers. I'll give you a minute from here. So about half of you have answered. The remaining people, quickly get an answer in. Okay. Quickly. Fine. So, right, there's a mix. I don't know if you guys can see. Let me know if you can or can't. But I've stopped the polling. Can someone message the chat if they can see? Great, fine. So, a bit of a spread here. Thank you very much, Mariam. Half of you really have gone for number 2, and the other half have gone for number 4, with a few other dotted about the rest of them. And this is a really mean question. I reckon most people who went for 2 or 4 are probably confused between the two. Would someone be able to kind of explain a little bit why they went for 2 or 4? And while we're going through that, let's brilliant. That's exactly it. Rajeshree's gone for the trick that I was trying to get you guys to look at, okay? So yeah, MONAC is definitely the way forward. What's going on here? This is a man who's presented with central crushing chest pain radiating to the jaw. So that is very cardiac sounding chest pain. And the moment you hear that, you really need to think, okay, could this be an ACS in our hands? Is this an emergency? Diaphoretic, so very sweaty, very nauseous, often symptoms associated with acute coronary syndrome, but no dizziness, which is another symptom. And the crucial thing here, our observations are stable. Everyone learns MONAC, and everyone learns, this means to give morphine, oxygen, nitrates, aspirin, clopidogrel, do their ECG, give their antiemetic, etc. But a lot of those things you actually only give if the patient needs. So what's the essentials out of the acronym? Aspirin. If you've got an ACS in your hands, everybody needs to be loaded on 300 milligrams of aspirin. almost everybody will be given a second antiplatelet as well, okay? And that can vary depending on your trust, from clopidogrel to ticagrelor, prasugrel, and we'll talk a little bit more about that later. Oxygen only actually gets given if a patient has stats less than 94%, and his observations are stable. So you know from that he doesn't actually need oxygen. The other thing, I mean, for those people who went for one, that is, often the long-term management. Well, maybe not SGLT2s if they don't have heart failure, but definitely the rest of them are. And those who went for, again, 3 and 5, we wouldn't give statins or beta blockers in the acute phase. Here, we're really trying to manage the acute problem, which is we have a blocked artery and we need to unblock it somehow. So we have ACS. And I guess we can kind of guess that from the history. We look at the ECG, and the ECG shows ST depression, all right? And it's quite in the lateral leads, well, yeah, even these anterior leads as well. But V4, V5, V6, 1, AVL, there's very clear ST depression, so a little bit of, I guess, some T-wave inversion going on too, all right? AVF, you have AVF2 as well. So there's very clear ST depression. And from that, the diagnosis with this is most likely going to be STEMI, okay? We would need a TROP as well, but most likely we're going to be having an STEMI on our hands, and we need to treat this as ACS. And the answer, therefore, is number 4, okay? Aspirin, ticagrelor, and fondaparinux. When you have a STEMI, that's the treatment that we're going to give in the short term. And in terms of the fondaparinux, how much we give varies depending on the trust. Fondaparinux is kind of similar to your heparins. It's an anticoagulant. So we've given dual antiplatelets in terms of aspirin and ticagrelor, and that knocks out the platelets. And then we're knocking out all the clotting factors as well of the fondaparinux too. And that is shown to be preferential compared to low molecular weight heparins, etc., which is why we give it. Typically, it can vary, but I think the trust I work at, for example, we give 3 days of fondaparinux. And this brings us on to our first topic, acute coronary syndrome. Now, there's 2 main types that everyone knows about. There's your ST elevation, your STEMIs, and your non-ST elevations, your NSTEMIs. And we'll start off with the STEMIs because these are probably the biggest emergencies that you'll face in cardiology, really. What they are, pathophysiologically, is literally an occlusion, a total occlusion of a coronary vessel. Once you get that total coronary occlusion, there is a lack of blood supply downstream of that artery. And actually, the severity that you're going to be causing in terms of ischemia downstream of the artery depends on how sudden or how short-term this occlusion has been. Okay, if it's a gradual, chronic, slowly worsening occlusion, then actually the damage might not be so bad because you're more likely to get some collaterals. But if it's a sudden occlusion, it's a thrombus that's blown up and completely blocked the artery, you're going to get very severe symptoms, very severe ST elevation. The way to look at it as well, in terms of the pathophys, is that the coronaries they run on the outside of the heart, and they kind of engulf the heart from the outside, wrapping it around. So if you get an occlusion, you're going to really cause ischemia to the whole wall, which is what we call a transmural ischemia. However, in an ST elevation, what's going on is you've actually got a partial occlusion. So it's blocked, but there's still some supply going. Unfortunately, that blood supply is not enough to prevent ischemia, okay? And there is still myocardial damage occurring. But because the arteries wrap around the heart from the outside, the damage will be actually furthest away from those arteries, which is what we call subendocardial ischemia. So in NSTEMIs, or non-ST elevation MIs, it's a partial occlusion, and the damage to the myocardial wall is subendocardial, it's not transmural. Okay? However, there is a third part of our ACS, and that is the unstable anginas. In terms of differentiating an NSTEMI from an unstable angina, it can be quite hard, and what we really need is that troponin level, okay? Because an unstable angina can have very similar presentation. You've got your chest pain, it's not resolving, you've got ECG changes even, but the troponin is normal, and that means there is no myocardial damage as of yet, okay? The myocytes aren't bursting and releasing troponin. So, this is a little bit about unstable angina. It's effectively defined as what we have here, okay? So it's angina, which is prolonged, lasting more than 20 minutes, with a new onset and it's severe, or it can be increasing in frequency, longer in duration, or lower in threshold, and this is often something known as crescendo angina. Or it can also be a chest pain or angina that occurs after a recent episode of an MI. This is a clinical assessment, all right? We don't really need any other tests, because if you have chest pain, you've got a normal trop, that's it, this is unstable angina. ECG changes may be present, but they don't really change diagnosis, okay? Also, if you guys have any questions, just pop it in the chat and we'll go through them. In terms of angina, again, a term which is often, we all throw around, but actually defining it is really, really important. And what it is it's typical chest pain related to the heart, so a constricting discomfort in the front of the chest or in the neck, shoulders, jaw, or arms, so that radiating central chest pain to the neck or down the arm. It's precipitated by physical exertion, and it's relieved by rest or by GTN in about 5 minutes, okay? We often get these sympathetic symptoms as well, which are associated with them. And these are your nausea and vomiting, sweating, palpitations, and dyspnea. And often when somebody does present with an acute myocardial infarction, they will have this whole myriad of symptoms associated with the anginal pain as well. So it's important to look out for them and notice them in your patients. In terms of investigations, we've kind of mentioned them already. Does anybody know any investigations that we want to do? A troponin, yep, definitely. ECG, troponin, observations, exactly that. Functional testing and anatomical testing for angina. Okay, nice. So, in terms of anything, how the best way to always present investigations is always your bedside, your laboratory, and then your radiology. So your bedside investigations that we're going to want to do is definitely going to be an ECG. We're going to want to do a full set of bloods, but really we're really focusing on that troponin. And troponin, we want to get serial troponins and serial ECGs as well, okay? The reason being, we can have a change in our ECG, ST elevation, ST depression, T-wave inversion, or Q waves. But is this new? That's so important, because if this is an old change that was present 1 year ago, then it's unlikely going to be an ACS, okay? So we need these new ECG changes that are changing whilst you see them. So for example, if you see somebody who has only T-wave inversion, you do a repeat ECG in half an hour's time or an hour's time, and they now have ST depression alongside their T-wave inversion. That's all really in keeping with this cardiac and STEMI picture. So dynamic ECG changes is good to look out for, and a dynamic raised troponin is also really important as well. It's one thing having a raised troponin. Many things can cause a raised troponin. For example, poor renal function can cause a raised troponin. But is your troponin going up and then down? If it is, there has been an acute event which has caused a troponin leak, and that, again, it points towards an ACS event, okay? So serial troponins, serial ECGs. Another thing that is really important is an echo. What an echo will give us is, one, the ejection fraction, but two, it's also important to look for regional wall motion abnormalities. What these are is, if you imagine the kind of the ventricle of the heart as it contracts symmetrically, all in one nice motion together. If you have myocardial ischemia or a lack of blood supply to the part of the heart, you often get territorial reduced motion, and this is called a regional wall motion abnormality. So if you have a lateral part ischemia, then the lateral part of the wall will contract less well. And again, if we find this on a echo, then this all points towards an ACS or a heart attack having happened. We have a question about, is anginal pain referring to stable angina? So anginal pain can refer to stable angina, but also even ACS pain is also known as angina. It is literally that central crushing chest pain that radiates to the jaw, brought on by exercise, or worsened by exercise. But really, it's just that typical pain there. Okay, stable angina is the weaker spectrum, which is where you have that pain that kind of goes when you walk, gets better when you rest, etc. Okay, so in terms of management, we've spoken a little about this already, but the first thing we want to do for a STEMI is load an aspirin. Okay, everyone needs to be loaded an aspirin 300 milligrams as soon as possible. Then we kind of get to the next stage, which is how quickly have they presented and are they fit for any interventions? And these are really important because if somebody is, 100 and something years old, they've had a STEMI, they have huge comorbidities and they're not going to survive a PCI, then we're not going to treat them with a PCI, okay? In fact, we might not even give them fibrinolysis either. We'll just go down the medical management route instead. So it's all really depending on the patient's condition. With regards to So with regards to how quickly they've presented is also important because we want to ideally be treating them before the myocytes have had time to die, which really in this kind of condition we want to treat them within 12 hours of symptom onset. And it's really important that we do that. So the numbers need to have presented within 12 hours, and if we can PCI them within 120 minutes, then we'll PCI them immediately, okay? In most places, especially in places like London, for example, that's going to happen. But in some of the more rural places where you're quite far away from a PCI center or from a cath lab, then you may want to fibrinolyze them first, all right? We will get to the questions in a minute. Okay, but they're all really good questions. Fine. So in terms of, we've gone down the PCI fibrinolysis route. The other really important thing is giving a second antiplatelet. Now, typically, this will vary on the trust. NICE tends to prefer ticagrelor, and I guess for exams, ticagrelor is the way forward, but it will depend on what agreements your trust has made in terms of drug availability, really. It can be from clopidogrel, which confers the lowest bleeding risk, and also has the weakest action on antiplatelets, to ticagrelor, which is kind of in the middle for both, to prasugrel, which has the strongest antiplatelet action, but also confers the highest bleeding risk. So naturally, which one of those you give depends on how worried are you about this patient's bleeding risk. Have they had a previous bleed at a critical site, for example, a stroke, etc.? Do they have a present hematoma? These are all things that can happen and you would want to take into consideration. In terms of a PCI, what this is, it's literally a catheter that gets inserted into the radial artery or the femoral artery. We go into the coronaries and we just put a stent with a balloon as well. The stent is normally drug-eluting, so it helps anticoagulate, and that all helps there. Cool. Just with these questions, can you please repeat what the ECG changes were that you want to check in your serial ECG? You're looking for any dynamic changes, okay? So the first thing is, has the ECG that you've just seen and you're querying an ACS, is it any different to the previous ECG from 3-4 months ago, i.e. prior to the event happening? Because often people can have long-term changes in their ECG, which may look like an ACS if you haven't seen the previous ECGs, okay? So it's important to make sure that these changes that you are querying ACS for are new. And if they're not, then it's less likely going to be ACS. And that can literally be anything. That can be a T wave inversion, an ST elevation or depression, or a Q wave. All right? So kind of make sure that those changes on you. Would you do a CT, MRI, coronary angiogram? So this is a bit of a more niche question, but it's a good one. In an acute STEMI situation, you would go straight to angio. So an angiogram is where you put a catheter in, as I described earlier, and you literally just shoot dye into the arteries. And you can visualize the coronaries that way. CT or MRI are non-invasive, and they're used more for when it's a less clear-cut case. So you might have some ST depression, you're querying an NSTEMI, but it's not so clear, and the patient is very stable, they're quite old. Let's go do a CT or an MRI angiogram to kind of visualize the arteries before we actually do anything invasive. Okay, so that's more for the stable patients who need less pressing urgent intervention. An LVEF, reduced LVEF. Well, reduced ejection fraction, it means that the heart is pumping less blood out of it. If it's new, then you might have a new heart failure, or it'll be typical in terms of the heart not pumping as well, especially in the acute phase of MI. That might improve with time even. So if there is a new sharp reduction in EF, that should point you towards an ischemic event having occurred, especially if it's sudden. So for example, we have an echo 6 months ago or 3 months ago, and LVEF was 60%, and now it's 30. That is a big jump. Something has happened, likely an ischemic event. Loads of questions. Oh dear. Okay. For the echo, would it be transthoracic or transesophageal? Generally transthoracic. Transesophageal requires sedation and is longer, so we wouldn't do that typically in ACS. So is choice of AP? What do you mean by AP? Sorry. For Katie's question. Could we please have access to the slides after this? Yeah, we'll get you access to the slides, don't worry. Antiplatelet, Yes, typically it's trust dependent, but for exams, go with ticagrelor if you're kind of given the two, just because ticagrelor is the one that NICE seem to prefer, unless they're trying to push you down. This is a really high bleeding risk patient, go for cloppy, etc. So you do an angiogram before the PCI? Yes, you do. So you always do the angiogram before the PCI so you can visualize where the blockages are. What is the eligibility for reperfusion therapy? Is there a scoring system? Not really for STEMIs. For NSTEMIs, we have GRACE score, which we're coming on to. Okay, and this is it. So, NSTEMI management, very similar. We give the dual antiplatelets, aspirin, typically ticagrelor, fondaparinux as well. That's a big difference. So everyone would get fondaparinux. Now, there is the GRACE score. How much this is used in clinical practice varies, I will say. But for exams, I think it's probably the way to learn it. You do the GRACE score. If it gives you a low risk, then you kind of go down the conservative management. If it gives you a high risk or intermediate risk, then you want to go down the reperfusion route, which is going to be a PCI. How urgent that PCI is does vary depending on the patient's clinical condition. So if they're hemodynamically unstable, for example, their blood pressure is low, they're very tachycardic, then you would want to go down an urgent, nearly immediate PCI. But if they're completely stable, the symptoms have resolved, but an ischemic event did occur, and you do have a little bit more time. And I think from how urgent that you need to give a PCI for undergraduate exams, that is probably the amount that you need to know. I don't think you need to know any more than that. If another important point is on the bottom of both these NICE flowcharts, and these are all available on NICE, by the way, so I do have a look at them, is cardiac rehabilitation and secondary prevention. Okay, so remember cardiac rehab, especially in your OSCEs. It's a really good thing to say because it kind of is looking at the more holistic picture, and it does really help patients too. Okay, next question. Have a look at this one. I'll get the poll ready. Okay, it should be there. You guys can answer. Okay, 5 more seconds. Let's quickly go through it. And then, because I think we're running a bit behind. Okay, closing the poll. Closed. Fine. So, a bit of a mix, but largely number 4, with a few going for number 1 and number 2, and I can understand that. The diagnosis here is a STEMI, particularly an inferior STEMI, if you look at the ST elevation from 2, 3, and AVF. And an inferior STEMI means there's most likely going to be a right coronary artery disease, okay? Those who went for 1 and 2, I assume you're looking at the reciprocal ST depression in V1 and V2. And again, that can happen. But remember, when you get ST elevation in one region, often you will get a reciprocal ST depression in another, okay? So it's important to just take that into account, that actually the disease isn't in V1 and V2, it's where the ST elevation is, which is 2, 3, and AVF. And therefore, the answer is right coronary number 4. And I'm hoping you guys have all seen something like this before. It's just one of those things you've got to remember, unless you want to kind of visualize and work it out yourself, which again you can do, but we're not going to go over that today. 1 AVL, V5, V6, lateral leads typically going to be left circumflex or the diagonal branch of the left anterior descending. So these are all the coronaries which supply the lateral side of the heart. Inferior is RCA or left circumflex, often because sometimes you can have a right dominant, which is where the right coronary artery supplies the inferior part of the heart, or you can have, in fewer, rarer cases, the left circumflex supplies the posterior heart instead, okay? So, yeah, can be annoying. But anyway, and then your anterior septal leads, LAD, left anterior descending. All right. And in terms of secondary prevention, these are the long-term medicines after a myocardial infarction that someone is going to be on. The most important thing really is going to be modify risk factors, okay? So if they're hypertensive, treat that. Type 2 diabetes, treat that. If they're smoking, get them to stop, improve diet, exercise more. These are really, really important because they will prevent another heart attack happening, or they will at least reduce the risk of one happening, okay? The other things are generally everyone is going to be on dual antiplatelets at least for a year, with then one antiplatelet continued long term. It's again going to be aspirin and one of the 3 that we mentioned earlier. Everyone will be given a statin unless contraindicated, 80 milligrams compared to a normal dose of 20, so it's a high dose statin. We like to give an ACE inhibitor as well that provides prognostic benefits, so things like ramipril. Atenolol is not really given, generally it's bisoprolol for the beta blocker. And then if they have heart failure and they're not really well controlled on the ramipril and the bisoprolol, then you can give a Pleronone or other aldosterone antagonists like spironolactone as well. Okay? We'll get to heart failure in a bit. But these are the long-term secondary prevention medicines that we give to prevent another MI happening. And they are really important. They really do make a difference. Okay. Third, SBA. Have a look. Oh, questions. I'll answer them in a minute. Let me just create the poll. So, what do patients usually get in cardio rehab? There's a cardio, often like a nurse or a PT or OT that come and they just help in terms of one, what they can do in life, options they have, and also, I'm actually not really too sure, to be honest, what happens in cardio rehab, but one to look up. So even if patient is very unstable and needs PCI immediately, would you always do a coronary angiogram, CT angiogram before PCI? So if they're very unstable, then we do a normal angiogram, not a CT, just because when you've done the normal angiogram, you then do the PCI afterwards. But it is important to do that initial angiogram because you won't know where the blockages are without visualizing the arteries. If they're more stable, that's when we get our CT angios or MRIs, stress perfusion MRIs done instead. Ting Feng Ho, how about V4, V6, V6? I don't know what you mean about that, sorry. Rajashri, sorry, what was right dominant again? So there's different types of cardiac coronary anatomy. A right dominant coronary anatomy typically means the right coronary wraps around the heart and supplies the inferior side, whilst the left dominant means the circumflex does that instead. Do you only give one dose of 300 milligrams? Yes. So it's one dose 300 milligrams, then a daily 75 milligrams, different to stroke. And when do you start secondary prevention medications? Really, once you've treated the initial problem, so you've had the reperfusion, and then you give the secondary prevention medicines. Definitely before discharge. For ACS in the community, can you give 300 milligrams clopidogrel or another antibiotic patient has an aspirin allergy? Yeah, provided they also don't have a clopidogrel allergy. And yeah, for HK. All right. Get your last few answers in. I'm going to close this poll. All right, stop polling. Cool. So again, a mix. People gone for 2 and gone for 4. Fine. With a few for 5, 1 for 1. All right. So let's go through what all these medicines are. Okay. Losartan, it's a angiotensin receptor blocker, an ARB. Works similarly to an ACE inhibitor, and you don't give both. So this patient is on ramipril already, so we wouldn't want to give losartan. Perindopril, no one's gone for, but that is another ACE inhibitor, and they're already on ramipril, so we wouldn't do that. Benzoyl is a thiazide diuretic. They're on indapamide, we wouldn't want to give that. Indapamide is a thiazide-like diuretic, okay? And is the third line medicine for hypertension. Eplerenone is another good one and would be an option here, but there's one thing that makes it less likely, and that's the potassium, okay? The two drugs that we need to know that raise potassium are your ACE inhibitors and your MRAs, your mineralocorticoid receptor antagonists, which are eplerenone and spironolactone, okay? If it's potassium is above 4.5, we tend to lay off those drugs and not give them, just because that can push someone into becoming hyperkalemic. And therefore, by process of elimination, the answer is doxazosin. It's an alpha blocker. It's pretty good, but it does have some side effects as well. Okay, and about 43% of you got it, so well done to those. So, hypertension. I think let's rush through this quickly, just because there's a lot to get through, and I think it's one of the topics that people know better generally. We define it as said there, above 140/90 clinic reading, ABPM is above 135 over 85, and there's two main types. The large majority of people are essential. This means that there's no really known cause, it just kind of happens, and often as we get older. Then there are secondary causes as well. They can be split into endocrine, renal, other drugs such as steroids, NSAIDs, and the COCP. Other things like pregnancy and coarctation of the aorta also can cause hypertension. You would generally only go and look for secondary causes if someone is hypertensive and they're less than 40 years old, all right? Or they're really, really hypertensive and they're a little bit older than that. And they're very resistant to medications. Lifestyle management that we can give are there. So these are kind of your classic of what's good for the heart lifestyle medications: reducing salt, reducing caffeine, reducing alcohol, don't smoke, that Mediterranean kind of diet that everyone goes on about, exercising more, losing weight, etc. Stuff that don't forget to stay in your OSCEs, because these are marks and they're so easy to miss because everyone always goes down the medical route. But again, when you're talking about medication, about treatment, always think first of all, what are the lifestyle changes that can be made? What's the pharmacological changes that can be given, or medications that can be given? And then what interventions can then be given? So things like, for example, a PCI, a surgery, etc. Okay. And I'm sure most of you have seen this. It's definitely a figure that I looked at loads. It's one from our best friend PassMed, and it kind of walks you through pretty well, to be fair, how to approach hypertension from a GP perspective. So you have a clinical reading of 140 over 90. White hood hypertension does exist. It can make someone's blood pressure seem higher than it actually is. So we always want to do a home blood pressure monitoring, ambulatory blood pressure monitoring, where we send them home and they record their own readings, okay? Depending on what comes back from that, as said here, is how it depends on whether we treat. So if they're less than 135, we don't treat, but we monitor very closely, especially if it's just under. If it's more than 135 over 85, with the following problems, so target organ damage, which can be literally things like retinopathy, or hypertensive retinopathy, kidney disease, etc., then we treat. Established cardiovascular disease, renal disease, diabetes, or a 10-year cardiovascular risk equivalent to 10% or greater. Probably the reason why I included this image is because I learnt this figure as like my gospel for hypertension, but I kind of come to realize there are a few things it misses, and this is one of them. If someone is less than 60 and they have a Q risk of less than 10%, NICE says to consider still giving treatment because that Q risk can underplay their actual risk of getting ACS or a cardiac event, okay? So we would still consider treating somebody less than 60 if they have a Q risk of less than 10%. The other changes will come to in a minute. Do both systolic and diastolic need to be raised? No. It's just as long as you have one of them, you can treat. And then if someone has a blood pressure of more than 150 over 95, you treat immediately. Okay? Another question, why don't you treat stage 1 hypertension in patients over 80? The reason being, as people get older, the whole point of treating hypertension is reducing the risk of a secondary cardiac event occurring, okay, or a cardiac event occurring even as a primary event. So if someone is reaching 80, 90, they're a little bit older, the long-term benefit we're going to give them by very tightly controlling their blood pressure is actually less. And we know that people as they get older naturally get a higher blood pressure anyway. So we're a bit more relaxed in terms of trying to maintain their blood pressure into a narrow range or low range. And we would only really treat them if they reached the above 150 stage, etc. I hope that answers that. Now, this is probably the most important part that PassMed figure does not include. And it's this bit at the bottom where it says blood pressure of 180 over 120. okay? This could be a medical emergency, and you need to refer for a specialist same-day review, so send them to A&E, ambulatory care, etc. if they have a retinal hemorrhage or papilledema, they have life-threatening symptoms, or have a suspected pheochromocytoma, okay? So if they've got malignant hypertension, very, very high hypertension, and you're worried about them, there could be some problem going on here, we need to do a same-day referral. Often, these will be the hypertensive patients who suddenly become hypertensive, and it's not a more gradual chronic thing. Because if it's gradual and chronic, your body adapts and responds accordingly. If it's a sudden change, your body is like, whoa, what's going on? It can't respond, and that's when you get problems. Otherwise, if it's above 180, you still assess for target, but there's no immediately life-threatening or worrying symptoms, and you go down the similar route as before, but you would still treat anyway, okay? And I've gone for the nice flowchart here, just because I like this one. I think it kind of covers it really well. I'm sure you guys kind of know this fairly well by now. First lines, if you're diabetic, if you're less than 55 and not Caribbean, Afro-Caribbean, then it's an ACE inhibitor and ARB. Typically, if people are not responsive or they can't tolerate an ACE inhibitor, then we give the ARB. A question that often gets asked is, what if they're Afro-Caribbean and diabetic? Then you go for the ARB, okay? If they're older than 55, then we go for the CCB. Then we kind of like to add the two together. So you can literally either do an ACE inhibitor or ARB plus a CCB or a thiazide-like diuretic, or you kind of mix and match with those. 2, thiazide-like diuretic generally tends to be indapamide, okay? Step 3 is you add all three together. Step 4 is the question that I asked earlier, which was quite mean, I'm sorry, but I was trying to emphasize a point where if potassium is less than 4.5, we give Spiro or a Pleronone. If it's more than 4.5, we give an alpha blocker or a beta blocker. Doxazosin generally tends to be given, but it has lots of side effects like postural hypotension, okay? Another thing that you don't really appreciate but can be useful in OSCEs is you're perfectly within your rights to say, just up titrate a dose. So if someone's on 1.25 ramipril, they've got a long way to go. Maximum dose is 10. You should really up titrate that before you start another agent. So always keep that in mind as well. Okay, that's hypertension done. Next question. Sorry, I have to make a new poll every time. All right, last few responses in. Quickly. Closing the poll soon. Okay, closed. Fine. So, nice. 90% of people have gone for ramipril. Good job. And so, what would we have here? We have a man with heart failure. He's known heart failure. Ejection fraction of 28%. So it's reduced ejection fraction. He's on a whole load of medicines, and we want to change one and add sacubitril valsartan. Does anybody know what sacubitril valsartan is? It's a new medicine. It's came out whilst I think probably all of us, if you're all final years, have been at uni. It's an ARNI. Yep, Entresto. Entresto is the brand name. ARNI stands for angiotensin receptor neprilysin inhibitor. So it does include an ARB, that's the valsartan part, but also includes a neprilysin inhibitor, which is the sacubitril, and together they're meant to provide a good benefit. I think the last time I checked, the studies showed it was equivalent to an ACE inhibitor, but there might have been more since. I'm not gonna bet my career on that one. But anyway, what do we know? We know if you're giving you cannot give an ARB and an ACE inhibitor together. Therefore, we must stop the ramipril before starting the Entresto. And that's the correct answer. Well done, guys. And this brings us on to heart failure. Now, heart failure can be tricky. I think the reason it's tricky is because there's so many different ways of defining it. The best way of looking at it is heart failure is an inability of the heart to really generate a cardiac output that meets the demands of the body, okay? And that can then be subclassified into certain different types. The most common one is preserved ejection fraction versus reduced ejection fraction. And if that wasn't confusing enough, the European guidelines then came up with a mid-range ejection fraction as well. The numbers are about more than 50% is preserved, less than 40% is reduced, 40 to 50 is mid-range. Reduced ejection fraction we can treat fairly well. We have loads of medicines. Preserved ejection fraction we have very few. I think we have one, and that's the SGLT2 inhibitors. Okay, very hard to treat preserved ejection fraction. It's a real problem in cardiology. Mid-range is a little bit of both. It kind of has signs of both, but it's still easier to treat than preserved. A lot of the reduced ejection fraction medicines still work. Another way of looking at it is left versus right versus biventricular. The reason why that's helpful is because often it tells you what symptoms you're likely to expect. And just think of it in terms of backlog, right? So if we have a left ventricular heart failure, you're going to be pumping less blood to the body. You've got more backlog backwards into the atria, left atria, and then into the pulmonary circulation. And that's when you get all your symptoms such as dyspnea, paroxysmal nocturnal dyspnea, your nocturnal cough, orthopnea, etc. All right? If you've got right heart failure, then the backlog is the other way. You get into the right atria, into the vena cava, and then that's where you get your peripheral edema and fluid overload, which presents there. All right? Biventricular is the worst. You get symptoms of both. Typically, it starts off as a left, causes backlog into the pulmonary arteries and pulmonary circulation into the right, and then the right can't pump enough, and then you get right heart failure as well, and then you get this biventricular heart failure, which is very hard to treat indeed. Another way is systolic versus diastolic. Reduced ejection fraction we call systolic, the reason being your ejection fraction is reduced, which means that your heart is contracting less well and is unable to pump enough blood. We kind of go down, for example, dilated cardiomyopathies, where your ventricle is very big, narrow walls, very weak myocardium, can't pump very well. Reduced ejection fraction, systolic dysfunction, okay? Preserved ejection fraction typically is more diastolic dysfunction. You have a very hypertrophic heart, very thick myocardium, doesn't relax very well, and that impaired relaxation means you're not pumping enough blood to meet the demands of the body. Crucially, however, you are pumping a normal ejection fraction. It's just not enough. And those are some of the common causes in the UK registry. What's the mechanism of SGLT2 inhibitors and preserved ejection fraction heart failure? I don't know. It's literally in the new guidelines, in the European guidelines. This year only included it, and the American ones from last year. In terms of how it helps, I don't know, sorry. But fine. Another important thing to note and really kind of memorize is the NYHA heart failure classification. It's a pain to memorize. It's really long, but just at least get familiar with it. One is the best. no symptoms, no limitation of physical activity. 4 is the worst, symptoms at rest. 2 and 3 are somewhere in the middle. All right. Typically, a question will give you one where the answer is 2 or 3, so they're not going to be as nice as that, but it's definitely one to look at. In terms of investigations, heart failure investigations, what do people have? What do you think we would want to do to investigate? An echo. Yeah, BNP, echo. Yeah, you're all on the right page. So, do an ECG. The reason being, often an arrhythmia can cause heart failure, especially if it's sudden. If you've got sudden heart failure, that's worrying, okay? And the causes of heart failure, we should really be splitting into ischemic versus non-ischemic, all right? If you have an ischemic heart failure, that suggests there has been something like a myocardial infarction, which has caused a sudden reduction in ejection fraction, weakness of the myocardium, and you're not pumping enough blood. That can be treated. Non-ischemic has many other causes. That's where you go down in the cardiomyopathy route, your hypertension, arrhythmias, etc. So an ECG is very important. For example, AF provides 20% of cardiac output. Sorry, the atria provide 20% of cardiac output. In AF, you lose that atrial contraction, and therefore you're losing 20% of your cardiac output. That can push somebody into heart failure if they have already some risk factors. All right. Likewise, bundle branch block is another cause of heart failure, and that is treatable with cardiac resynchronization therapy, which we're not going to go into today, but is interesting if you want to look into it. It's where I'll talk about it quickly. In bundle branch block, your ventricles aren't pumping synchronously, they're pumping at different times. That can reduce ejection fraction. If you synchronize the ventricular pumping and contraction with a cardiac resynchronization therapy device, you can improve ejection fraction and actually quite well treat somebody's heart failure. So that is a really interesting aspect to management as well. In terms of exams, ECG, NT-proBNP before the echo, all right? So you do this BNP, and if it comes in like raised but not super high, echo, swap those two around, okay? Raised but not super high, echo in 6 weeks. Very, very high, echo in 2 weeks, okay? Sorry, written the wrong thing there. Other investigations, do a chest x-ray and look for the cause, as we said earlier, about your ischemic versus non-ischemic, all right? This is your chest x-ray, and I kind of remember splitting it in terms of A, B, C, D, E. So look for your alveolar edema for A. So this is going to be, your peripheral edema. Just look at loads of pictures, get familiar with it on x-rays. It's got quite a characteristic look. B being the curly B lines. So if you look at the edges along the chest wall, there are some thickened lines that come out of the chest wall. That's your curly B lines. It shows fluid. C being an increased cardiothoracic ratio. Make sure you're looking at a PA film, not an AP film. And on the PA film, if it's more than 50%, then you have an increased ratio. D is dilated upper lobe diversion. So that's your dilated vessels. This can be quite hard to spot, but if you can kind of look at this picture, there's some tubes you can kind of see, or thickening alongside alongside the vessels, and that's your dilated vessels. That is literally backlog of blood going up into the lungs, okay? And then E is effusions. So you can get a pleural effusion, often such as blunting in the costophrenic angles, but you can also get horizontal fissure fluid as well, which is what we have in this picture here, okay? But do get used to looking at chest x-rays for heart failure because they can come up in exams. And this is the heart failure management. I'm going to rush through this just because we don't have much time. But we reduced and we have preserved. And they, as I mentioned earlier, have different treatments. The mainstay of treatment are your ACE inhibitors and beta blockers. If that's not doing enough, then you start a Spiro or a Plerone. often with the ACE inhibitors and beta blockers, you tend to not start both at once. You start one, titrate upwards, and then start the other, just because if you start both at once, you can drop somebody's blood pressure. Okay. Following the MRA, the eplerenone or Spiro, we then have a few other options, and this really depends on, I guess, what the specific patient's phenotype and what's going on. So, for example, ivabradine slows down the heart very similarly to, well, not similarly, but it slows down the heart like bisoprolol does, for example. Okay, it reduces sinus rhythm. So if someone's in sinus rhythm and their heart rate is quite high, then ivabradine is definitely an option because it reduces that sinus node activity. If you can always, as we mentioned that question, start Entresto or sacubitril valsartan if they have a very low ejection fraction. Hydralazine and digoxin are also options. Digoxin can be useful with AF as well because it helps slow that heart down in AF. The problem with digoxin is it's not very good with exercise. So if someone is doing lots of exercise, we don't like to give it. And it's given much less now, especially in heart failure. Okay, we don't really give it too much. This is just skip through that. Okay, so it's hit 8. I know we said we'll be 1 hour, and I'm very sorry. I've got about another 20 slides left. We're going to talk through valves, going to talk through, I've got a few ECGs at the end as well, and AF. So feel free to stay. If you're going to leave, that's absolutely fine, but can you please do this feedback form for me? It's really helpful, 1, because it helps guide us what we need to do next, and 2, helps us understand how we can improve our series as well, especially because we're at the start of the series. Any suggestions you guys want to include, just put it in there and we can include it, okay? So that's the form, and actually I'll just get a link as well. That's a feedback link too. If you're staying into the end, that's absolutely fine. But whenever you're leaving, just do that, please. Okay. Next question. Okay. Get your answers in, guys. All right, last few minutes. Closing the poll. Poll is closed. Okay. So, majority of people have gone for 3, with a few others going for 2, 4, and a few more for 1 and 5. Interesting. Yeah. So, what's the diagnosis here? Someone tell me. And on top of that, someone tell me why they've gone for 3. AF, fast ventricular rate. Yeah, exactly that. Yeah? We have someone who is in AF and they're hemodynamically unstable. Perfect. Really good job, guys. Yeah? So, what's the clues here? You have an irregular heartbeat. That screams AF at you. No real cardiac history previously, but they do have a lot of risk factors for AF. They've got anxiety, they've got big work deadline upcoming, very stressed, and they're fast, running 147 beats per minute, and that has caused them to drop their blood pressure. Okay? Similarly to what we said earlier about how arrhythmias can reduce cardiac output, when you're reducing cardiac output, that can then, because the heart is beating so fast, that can then drop someone's blood pressure, and that becomes an emergency that needs urgent treatment. Now, the urgent treatment in this case is going to be a DC cardioversion, okay? And that's the right answer. So well done. Ignore the heparinized. That is meant to be deleted. Now, this is a busy slide, and I'll just kind of break it down bit by bit. What is AF? AF is chaotic irregular atrial rhythm. So the atria are contracting at multiple different focus points all across the right and the left atria, such that they're basically just quivering, they're just shaking. There's no regular contraction of the atria, which means you have impaired pushing of blood down into the ventricles, okay? Because you have this constant electrical excitation going from the atria to the AV node, the AV node then just gets confused and kind of just responds intermittently, irregularly, and whenever it can. And that's what causes the classical irregularly irregular pattern found in ECG. Life in the Fast Lane described the causes of atrial fibrillation really well, and that's what I've included here. So it's a lot of text, but I just wanted to highlight you guys to this way of categorizing it. And that's one, atrial distension. Atrial distension works because you're stretching the atria, and as you stretch the atria, they have their own automaticity. So they have their own electrical excitation. And as you damage that, they can then start exciting themselves and start creating an atrial fibrillation arrhythmia, okay? You can also get conduction abnormalities, and for example, with ischemic heart disease, if you have damage to some parts of the myocytes, these can also become a focus point for electrical excitation. Increased atrial automaticity, meaning the atria, the electrical signals emanating from the atria increase in frequency. And these can follow things like caffeine, binge drinking, or electrolyte abnormalities as well. And then there's many other causes too. Important thing to know, often we don't find the cause. Lone AF is really what we describe, we don't find the cause, okay? The other important thing is classification of AF. And we kind of classify it as I've written here. So first detected episode, it's happened once, hasn't happened again, and you kind of just look and you think, is there a clear cause? Have they just had cardiac surgery? If so, you don't really need to treat it. It shouldn't really happen again, all right? Or if they have recurrent episodes, then this is where it starts getting a little bit more important to classify. If they've had two more episodes, but it's terminated spontaneously in less than 7 days, typically less than 24 hours, we call that paroxysmal AF. If it's not self-terminating, then we call that persistent AF, and the episode usually lasts for more than 7 days, but you can still normally cardiovert these ones, hopefully, with pharmacological cardioversion like flecainide or DC cardioversion as well. Okay. Permanent AF is someone who is in constant AF, they cannot be cardioverted, or we just think, you know what, we're not going to get involved, we're going to leave them in AF, that's probably what's safest for them. And I think there's been a huge amount of research, again, while we've been at med school, or while I was at med school, and while you guys are now, which has really kind of said, actually, rate control is often better than rhythm control. Because rate control, we know someone has AF, we're treating it accordingly, and actually if we treat it very well, it shouldn't really reduce someone's life expectancy. Rhythm control can be difficult because you're trying and they kind of go back into AF, and then it gets a little bit more challenging to kind of manage them. This is your classical ECG. The thing to note, probably, I've just seen this a lot, and again, I don't know if this is science or not, but what I've noticed is often you'll look at V1 and think, oh, that looks quite atrial fluttery. because you can see these flutter waves, but a lot of AF tends to have those flutter waves in that V1 lead. And if you don't really see them anywhere else, then you can think, okay, actually, it's more likely going to be AF. Atrial flutter often is a bit typically regular, but doesn't have to be. And it tends to be comes as multiples, not multiples. I forgot the mathematical word, but they can, as a heart rate that can divide into 300. So 150, 100, 75, etc. Okay? Cool. So atrial fibrillation symptoms are these. Often they're asymptomatic. And, there are loads of patients going out there who are in AF, don't realize, and that's why it's so important, especially for GPs, to always check a patient's pulse, because you can often pick up incidental asymptomatic AF. Remember, as we said earlier, it really becomes asymptomatic when that lack of 20% causes their cardiac output ejection fraction to drop and push them into heart failure. But if they're able to compensate for that lost cardiac output and they're not running too fast, then actually they won't have any symptoms, okay? The symptoms that you'll often experience will be palpitations, that's the main one, but you can also get dyspnea, chest pain, and rarely you can also get syncope or dizziness. But dizziness is a bit more common than syncope. Because I guess think about it, syncope is where cardiac output is not enough to supply the brain. At least cardiac syncope can be described as that, okay? And to get to that stage is quite difficult. In terms of management, the first thing you need to ask yourself, as we did in that previous question, is this patient hemodynamically stable? If no, then we need to DC cardiovert, okay? And often it becomes a risk-benefit ratio. I know I wrote heparinize earlier, but in reality, if someone is anticoagulated, then you take into the risk that you may cause a stroke by cardioverting, but because they're hemodynamically unstable, it's worth doing that anyway. If they are hemodynamically stable, then look, is there a reversible cause? Okay. Do they have an infection? Are they dehydrated? Do they have some thyroid abnormalities? So always check for thyroids, function tests. Do they have electrolyte derangements? If so, treat them and see if that fixes the AF. If it fixes the AF, and it's the first detected episode, and you've done the CHADS VASC score, and you think, well, actually, this person doesn't need any further anticoagulation, etc., then you know what? Well, then you're right to say, okay. But if it persists, then you need to start thinking, does this patient need rate or rhythm control? Do they need anticoagulation? And will an ablation be beneficial? For undergraduate exams, ablation is, I think, a bit above. Don't need to get too involved in that. But anticoagulation is something that we should probably try and work on to work out who needs anticoagulation. Now, for an undergraduate level, I don't think you would really ever get given a patient. I don't know, you might have a mean med school. But I don't think you get given a patient and they say, are you going to rate or rhythm control? But it's important to know the information that's required to feed into that decision at least. So, NICE advocate a rate control strategy, generally, unless they have coexisting heart failure, first onset AF, or when there is an obvious reversible cause. Okay, I guess that's important to know. So heart failure, first onset AF, or obvious reversible cause. If they have those three, then you can go down the rhythm route and try and cardiovert them back into sinus rhythm. Sinus rhythm meaning a P wave precedes every QRS complex. Rate control, the medicines we typically give are beta blockers or calcium channel blockers such as diltiazem or verapamil. You can consider digoxin if that's not working or helping. Sometimes it gets given. Again, it's not very good. We don't like to give it so much, and it doesn't really help if the patient does exercise. In terms of rhythm control, there's a few options. You have electrical cardioversion and chemical cardioversion. The two Main types of chemical cardioversion are amiodarone and flecainide. Sotolol is sometimes also given. Contraindications to flecainide are structural heart disease or ischemic heart disease. So if they're very young, you go on the flecainide route. If they're a bit older, then we go on the amiodarone route, or if they have, for example, structural or ischemic heart disease. That moment when you cardiovert someone is the highest risk for causing a stroke, because in your left atrium, you have the left atrial appendage, which is kind of like a sock that just sits there. And if it's not contracting very well, it's very easy for blood to get pulled in there, all right? What can then happen is once you've got blood stasis, you kind of Virchow's triad and you get the increased risk of clots, and that clot can just sit there. It's in the left side of the heart, remember. So when you cardiovert someone and you push them back into sinus rhythm, your atria suddenly contract again, and any clots that are sitting on that left atrial appendage can get pushed into the left ventricle and pumped across the body. Worst case scenario, that gets pumped into the brain and you get a stroke. So we only cardiovert if they're unstable, short duration of symptoms, less than 48 hours. So there's a clear history. Either you've seen it or the patient is very clear in their history, or if it's only started a few hours ago, doctor, I've never had any palpitations before. Or you anticoagulate them for at least 3 weeks before cardioverting. Or you do a transesophageal echo to exclude a left atrial thrombus. Again, that doesn't happen too often. Would you still do cardioversion for a hemodynamically unstable patient with permanent AF? So it's a hard one. I think if you've tried your medical management, so you've got somebody in AF, they're hemodynamically unstable, and you can initially give things like metoprolol or high-dose loading dose digoxin if they're not on it. Metoprolol is a fast-acting but beta blocker, but it has a short half-life, so it kind of goes quickly. And if they're not really helping, you try your medical management, then cardioversion is the next way forward. Would you chemically cardiovert in hemodynamically unstable but symptoms over 40 hours? We tend to do electrical cardioversion for hemodynamically unstable. To answer Stephanie's question. Okay. Now, anticoagulation. Anyone who presents with AF, even if it's paroxysmal, need to do CHA2DS2-VASc versus orbit score. All right. You'll often see has-bled floating around. When I was doing my cardiology rotation, orbit didn't exist, but in the last couple of years, it's kind of become more, it's been adopted already by NICE, and now we have to use that over has-bled. CHA2DS2-VASc score is your risk of clotting and risk of stroke. Orbit score is your risk of bleeding. You do both, and you kind of make a risk assessment or a cost-benefit assessment of which way to go for anticoagulation. First line is DOAC, second line is warfarin. Often you give warfarin when somebody has things like a mitral valve replacement, etc. Okay, well, I think it's mitral. It's one of the valves replacements. Then you give warfarin. Or any other contraindications one might have to a DOAC. But I think the key thing here is even if you have paroxysmal AF and you've put someone back into sinus rhythm, if their CHA2DS2-VASc score and orbit score say so, then you should still anticoagulate. The reason being, you don't know when this person is going to go back into AF. And when they go back into AF, that risk of stroke happens again. Just a little bit on atrial fibrillation as well, compared to atrial flutter and multifocal atrial tachycardia. We would anticoagulate all three of these. That's important because the risk of you have impaired atrial contraction, and when you have impaired atrial contraction, the risk of a clot always exists. With atrial flutter, you kind of got that very sawtooth, characteristic sawtooth appearance. You all know how that looks. Multifocal atrial tachycardia is where you have very different looking P waves. And if you look at this picture, the P waves all look slightly different. One's negative, one's very high, one's low. And what that means is that the focus point of the start of atrial contraction is not actually in the sinus node, it's coming from various points along the atria. And that's causing this multifocal, what we call multi-focus points of initiation, atrial tachycardia. That also needs to get anticoagulated. What are the contraindications to a DOAC? So DOACs are fairly new medications. I think the evidence base isn't there for a few things. So, for example, if you have a large body habitus, so I think maybe above 100 kilos, we don't like to give DOACs just because the evidence base isn't there. We don't know how much to give. You need to sometimes consider renal function as well. And also if you have valve replacements, there's certain valves which are replaced in which you can't give DOACs and you'd rather give warfarin instead. Okay? And the INR range for some of these is generally higher because with valve replacements, you have an increased risk of clotting. I hope that answers your question regarding contraindications to DOAC. Okay. Next question. Sorry guys, we're running very late. And I mean, I'm doing this and I will upload it anyway, but feel free to stay. I really appreciate it. And if you want to leave, just please fill the feedback form. Okay. Get your answers in. Last few answers. Going to close the poll. Going to close it. Going to close it. It is closed. Okay. So most people, 61% have gone for number 4. A few gone for number 2. A few others for 1, 3, 5. Okay. So murmurs, valve disease. In terms of, what's this question saying? So this question is saying someone who's come with symptoms of heart failure. They've got worsening dyspnea. Okay? And we have multiple causes of heart failure, as we mentioned earlier. One of those is valve disease. The GP hears a mid to late diastolic murmur, and therefore, which of the following is the most likely cause? A mid to late diastolic murmur. So, out of these, the diastolic murmurs are going to be aortic regurg and mitral stenosis. So we know it's going to be one of 2 or 4. Aortic regurg is an early decrescendo murmur. So what does that mean? It's loudest at the start of diastole and gets quieter. The reason being, at the start of diastole, what is aortic regurg? Aortic regurg is the flow of blood from the aorta back into the left ventricle. Okay? At the start of diastole, systolic pressure is highest, it's greatest. The reason being, you've just pumped a whole load of blood into the arteries, very high pressure. Equally, ventricular pressure is at its lowest because you haven't got much blood flowing into it. It's a kind of an open cavity. That increased pressure gradient means you have a lot of black backflow of blood going through the aorta, through the aortic valve back into the ventricle. Okay? That's why you therefore get a decrescendo murmur, i.e. it's loudest at the start and gets quieter along diastole. Think of mitral stenosis. The atria contract. What is mitral stenosis? Mitral stenosis is a small opening of the mitral, or is reduction in the size of the opening of the mitral valve, which connects the left atria to the left ventricle. Now, there will typically be blood flowing through it, and in more mild to moderate mitral stenosis, what happens is when normal flow of blood, that doesn't make any noise. But once you get atrial contraction, you suddenly push a whole load of more blood through that narrow gap, and that creates a murmur. And that can create a mid to late diastolic murmur. Okay? So as mitral stenosis gets more and more severe, that murmur becomes earlier and earlier. But if you hear a mid to late diastolic murmur, think mitral stenosis. And that's the answer. All right? Next question. What is the cause? This is like a classic pass med question. They love this. Okay, last few votes. And I'm going to stop polling. All right, so bit of a mix between 1 and 2, and then a couple people going for 4. So this is one of those things that you've either seen it or you haven't. The most common cause of mitral stenosis is rheumatic fever. Rheumatic fever is much more common amongst people from developing countries, but even in the UK, the most common cause is still rheumatic fever. Okay. Many other valves classification would be the right answer, but for mitral stenosis, it's rheumatic fever. It's just one of those things that can come up in SBA, and it's good to know. This is a nice image. I got it from some website, I think maybe Geeky Medics. And it kind of explains a little bit what I was talking about the decrescendo aortic regurg murmur. If you can see, it's kind of the wavelength is greatest at the start and then gets quieter and quieter throughout diastole. Whilst mitral stenosis, you can kind of see the rumble only really starts midway through, gets worse later on. With an ejection systolic murmur, what is a really good way of kind of doing it is if you have a stethoscope, put it on, hold your the diaphragm of your stethoscope, and then kind of trace a circle. And as you trace a circle, what you'll hear kind of sounds like an ejection systolic murmur. And then when you go like that on the diaphragm, what you'll hear more is a pansystolic murmur. Okay, and it actually does kind of sound like that in real life as well. Some doctor taught me that when I was at med school, but it is useful. Okay, think about ejection systolic murmur. It's crescendo, decrescendo, quieter to louder, and then quieter again. Whilst the pansystolic is more just the same. It's just a consistent flow and a consistent sound, effectively. All right. Cool. Now, aortic stenosis is the most common valvular disease. Many causes, degenerative calcification, it's a big one, especially amongst the elderly. If you're a bit younger and you've got aortic stenosis, then think, okay, there's something going on here. So, for example, bicuspid aortic valve disease. If you have, Williams syndrome is always one of those ones that is great to say, not OSCE, but like in real life, how often are you going to see it? It's where you get a supravalvular stenosis, still causes that ejection systolic murmur. Post-traumatic heart disease, HOCM as well. HOCM causes left outflow tract obstruction. So you get that obstruction just below the aortic valve. And that's one of the main signs. It's hypertrophic obstructive. The obstructive means you get that left outflow tract obstruction, cardiomyopathy. And the symptoms are, as we said earlier, often about the heart failure. So you're going to get your, dyspnea, PND, orthopnea, etc., especially if it's quite bad. If it's very bad, you can even get mitral regurg. And often as part of the workup to aortic stenosis replacement, We need to assess the mitral valve as well, because sometimes what you need to do is actually say, well, they're both now not working well just because we've missed the boat. And actually it makes sense to treat both at the same time, the mitral valve and the aortic valve. Other signs and symptoms you can get are syncope. Aortic stenosis is always an important thing to consider in syncope. A narrow pulse pressure, a slow rising pulse, soft or absent S2. The reason being S2 is caused by closure of the aortic valve leaflets. If they're very calcified, if they're not opening very much as it is, then as they close, it's going to create less noise. And a thrill is literally a palpable murmur. Fine. Investigations, ECG, but ECG to look for an arrhythmia that can sometimes be caused by aortic stenosis. The reason being the heart has to kind of pump way harder to get that blood out into the systemic circulation. As it does that, it can become hypertrophied. You can get some ECG changes. The other thing is echo, because echo will let you characterize very well how severe that aortic stenosis is. And I've kind of made this aortic stenosis management flowchart. How useful this is for exams, I'm not sure, but it's good to kind of have an appreciation of it. The first thing is always, again, think, is this person medically fit for surgery? If no, then you're going to medical management. You're going to kind of treat the heart failure symptoms. If yes, they are medically fit for surgery, then think, okay, are they symptomatic? And if they're symptomatic, then you go down surgical aortic valve replacement or TAVI. The difference being surgical aortic valve replacement is cardiothoracics. They get involved and they open the heart and they change the valve. A TAVI is transcatheter. So it's kind of like you go through the arteries and you put a catheter in up into the aortic valve and you replace the valve that way. Typically, TAVIs are for patients who aren't medically fit enough for a surgical aortic valve replacement. Okay. And then there's this whole criteria found on echo. So, for example, a narrow aortic valve area, if you have a very peak velocity, low ejection fraction, etc. Or you can do exercise testing. And if exercise testing causes symptoms such as angina, dyspnea, etc., then that can also be an indication for valve replacement. Mitral regurg is another one. It's the second most commonest, and we'll talk about that. It can be acute or chronic, and acute is an emergency. It can also be ischemic versus non-ischemic. These are some of the causes. I'm going to kind of brush through it very quickly. The main thing to know is the mitral regurges and the tricuspid regurg. You get the pansystolic murmur. Again, you can get LV hypertrophy as well, because the heart is trying to pump harder to get that blood out into the systemic circulation rather than the atria. And as a result, you can get arrhythmias too. So there's this whole aortic regurg eponymous signs. I'm not going to go into them, but they are important to know. They come up in myoscopy, and they can come up in others, I'm sure. Yeah, I'm not going to go through them. This is more just rote learning. The thing to note with aortic regurg, typically, you hear it loudest not over the aortic region, but over the tricuspid region. Why? I guess it's because, as you think about it, what's causing that murmur is the turbulent flow of blood through the aorta into the ventricles. And therefore, that turbulence of flow into the ventricles is where that murmur emanates from, and typically you can hear that loudest over the tricuspid valve, or the tricuspid region. All right? Aortic regurg is more common than tricuspid stenosis. So if you hear a diastolic murmur of the loudest of the tricuspid region, do have aortic regurg as a differential. Registry, what did you say you could do on the stethoscope to mimic a pansystolic murmur? Hold the diaphragm out in front of you and just kind of place two fingers and go like that. And you get like a rush of blood, basically, that you can hear. It's quite cool. Very quickly, heart adapts to valve problems. It can either hypertrophy or it can dilate. This is just a quick bit in terms of what causes hypertrophy, what causes dilation. Okay, but for interests of time, we will ignore that. Okay, all right, 58 people still on, so we're doing well. We've lost about half, but we're doing all right. Thank you guys for staying. Really appreciate it. So, ECG spot test. Just got a few ECGs. Let's go through them. Have a look. I'm just making the poll. Okay, last few responses. Stopping polling now. Nice. So 75% of you have gone for number 5, second degree heart block. Well done. That's the right answer. Yeah. And I wanted to use this to talk a little bit about heart block, but not too much. Heart block is what? It is where you have AV node. There's something in the AV node that's preventing or reducing the electrical excitation from the atria to the ventricles. Okay. PR, that PR interval, is effectively telling you the function of that AV node. Okay. So when you have an increased PR interval, there is something going on the AV node that's meaning that signals are taking a little bit longer to pass through it. Normal PR interval is 120 to 200 milliseconds. Anything more than 200 milliseconds, first degree heart block. Then we have second degree heart block. Second degree heart block has two types, Mobitz 1, Mobitz 2. Mobitz 1 is where the PR interval gradually, as you can see in this ECG, gets longer and longer and longer before suddenly dropping. You have a drop beat, P wave, no QRS. And you can see that kind of in this ECG here. Mobitz type 2 is where it's just normal PR interval, QRS, normal PR interval, QRS, bam. Sudden, or like not normal, but like a consistent PR interval, consistent PR interval, and then a dropped beat. Okay, and that is much more serious and much more severe just because there's less predictability about why that beat is dropping, and we would be more likely to treat a Mobitz type 2 than a Mobitz type 1. The other thing is then complete heart block, which is where there is complete AV dissociation. P waves are firing, QRSs are firing, they're not talking to each other, the AV node is not working, and they're both just kind of going off and doing their own thing. All right. The thing to note is on an ECG, take your ECG, take a blank piece of paper, and just mark out the ventricular beats, mark out the P wave beats, and if you have a consistent space between the P wave beats and a consistent space between the ventricular beats, but they're not really in line with each other, there's different gaps, then you can think, okay, there's AV node dysfunction. This is third degree heart block. I hope that makes sense. All right. Next one. Just for the interests of time, do you guys want to just shout out the answers in the chat? Just put in the chat, let me know. Okay. Anymore? Is everyone's brain fried? Can't look at an ECG anymore? I am. Can't imagine how you guys are feeling. Okay, cool. So one left bundle and majority going for right bundle. Yeah, this is right bundle. Okay. Now, why is it right bundle? In right bundle branch block, the characteristic thing is in V1. Everyone knows William Marrow. I find William Marrow impossible to interpret. Like, I know WV1 for left bundle, etc., but how often do you see that W? You barely see it, and you spend half the time like, oh, I don't know. So how I've done it is always look at V1. Okay. First of all, approaching. How do you approach the QRS? If the QRS is greater than 120 milliseconds, then there is some disease there. Okay. You either have ventricular tachycardia, where the heart rate is beating very fast, it's going its own, it's creating its own waves and its own beats, and it's greater than 120 milliseconds. Because what that means is, if it's less than 120 milliseconds, the wave is going through the AV node, down the Purkinje fibers, but down the bundle of His and the Purkinje fibers, which really transmit electrical excitation very quickly all across the heart, all across the ventricles. If you have that signal coming from anywhere else, then you will have a longer time to excite both ventricles, simply because they don't go down those bundle of His and Purkinje fibers, which are very fast. That portrays an ECG as a QRS more than 120 milliseconds. So if you're fast, think ventricular tachycardia. If you're normal, or you're fast but have morphology typical of a bundle branch block, then think bundle branch block. All right. So in the back of your mind, always think when you have an increased QRS, is this bundle branch block? With right bundle branch block in V1 and sometimes in V2 and V3, you have a very characteristic RSR pattern. Okay, so what does that mean? In your QRS, Q is that downward deflection initially. Not every lead will have it. R is the first upward deflection. S is that another downward reflection. And then you go to normal. Okay? When you say RSR, you are literally saying one upward, one downward, another up. And that's your M for Marrow. Okay? And you can see that really nicely in V1, V2, V3. You have that RSR pattern, which is the N. With right bundle, the other way of looking at it is, if you look at V6, you often have a slurred upstroke in the S wave. So as the S wave comes back up to the isoelectric baseline, it can kind of take a little bit longer and it's quite slurred. And that is also generally what I've found to be quite characteristic of right bundle branch block too. Okay. In left bundle branch block, it's a little bit different. You'll see there's no RSR pattern and actually have a very, very deep S wave in V1, V2. Okay. And this is quite characteristic of left bundle branch block. So you have a raised QRS. Think, is this right or is this left? If there's RSR in V1, it's right. If there is a deep, thick S wave in V1, it's left. And that is a fairly good way of trying to distinguish and differentiate between right and left bundle branch block. Okay, next one. Again, you guys just put in the chat. Sorry, might be a bit small. All these ECGs are from Life in the Fast Lane, by the way. Life in the Fast Lane is amazing. I'm sure you know. It's great. I love it. Okay, STEMI. Any more? Okay, fine. Acute pericarditis, interesting. Okay, so two main things here that you're really going to consider. STEMI, acute pericarditis. Okay? What's going to differentiate really between the two? One, really, whenever you see ST elevation, think those two things. Most likely going to be STEMI, that's your real worry, okay? But if there is global ST elevation across all leads, not really inconsistent with one coronary territory, then think, ooh, that's not normal. That's not your typical ST elevation that you expect. If it's very saddily, so kind of as you've seen in V5, V6, lead 1, it's like a saddle shape, that's quite consistent with acute pericarditis, ST elevation. Okay, so ST elevation in acute pericarditis is typically global, it's saddle shaped, and you'll get some PR depression between the P wave and the QRS. So you can see it a little bit in lead 1, for example, that PR interval is just slightly lower than the baseline, and a few of the other leads as well. Okay, so those are your pericarditis stuff. Cool. Okay, so we got there. Thank you guys very much for staying. I hope that was useful. Do let me know. Please answer the feedback. Let me know if you would want more lectures on cardiology. What I was thinking is doing one specifically on ECGs. I think ECGs are really difficult, and that would be quite useful for people. I mean, I like cardio, so I was even thinking doing like an echo course for final years. I don't know if you find that interesting. What else? I guess there's a lot of other things we didn't cover. So, all other things like tamponade, etc. We can do another lecture for that. But yeah, please do the feedback form. Really appreciate you all coming. If you have any questions, pop in the chat now. Happy to stay another 5 minutes and talk through things. I'm sorry I was a bit rushed towards the end. And you're welcome, everybody. Thank you for coming. Gastro session is this Thursday, so that should be the 2nd. Okay. All right, I'll log off. Thank you, guys.